take up the next 3 hours asking questions, but I want if people could, yes, Shelley.
Yes, Shelley Green for the UCI. I wanted to ask Ruth and Rob. Rob referred to it. How do we get to a culture of equipoise, where equipoise can be defined and appreciated by both the providers and the patients, so that a doctor can say to him or herself and to a patient, I do not know whether the next question I'm asking, the next test I'm doing, the next image I'm doing, the next treatment is doing, I simply do not know whether one is better than the other. Because as Rob kind of point was alluding to, our culture, our medical culture, more or less wants the opposite, and many patients want the opposite. So if we're going to intertwine research with practice and say that almost everything we do is actually an experiment anyway, which is kind of what we're saying, how do we get from here to there?
I mean, I've been thinking about this a long time because early my career in 1978 was doing decision support about bypass surgery using a database, as you know. And the majority of people, at least in North Carolina at the time, after you showed them the data, they'd say, well, Doc, what do you think I should do? And that's what they wanted to hear. And I still think that's a primitive part of all of us that we would like a person we rely on to be able to give us advice. But I think we can get partway down the road now by having a more explicit national discussion, and I think it's time to do it. I think if we go too far down the road of ramming it down people's throat that we have no idea what we're doing, in practice, it'll undermine, the well-being of a lot of people who do need the trusting relationship with a healer or a provider to sort of get through the day. But I think I have a sense there's enough leeway here, but to do it, it will take this, I showed that slide of all these people and agencies. It will take an army of people to be a little bit on script, not to prescribe what the right answer is, but to really have the discussion so that the consumer groups and patient advocacy groups, which is where I think the action is, can do their part.
Yeah, I would agree. I think we struggle with striking this balance between the need to have a broader shared understanding of the culture of equipoise and, as Rob described it, not undermining either the desperate need of people who are ill or potentially at risk of becoming ill, that they can count on the good judgment of the people taking care of them, and also the professional integrity of the clinician who wants to believe that she has something to offer, which she does, even in the context of uncertainty or considerable uncertainty. I'd be uncomfortable about rolling out a national initiative on the culture of equipoise. Right? The language is freighted, to say the least, and contested even among people who work with it as a technical matter, and it's really scary, I would guess, if we tested it in focus groups, as maybe not the best way to roll out what's at issue, and I don't even think that is what is at issue. But I couldn't agree more about the importance of engaging consumers and patient groups. It's a project that we're now trying to roll out ourselves at a small scale with some PCORI support and want to do it at a much larger scale going forward. But I also think that it's got to be part of a larger strategy in which we say to each other, it's not only we have a problem, but we've got a solution, right? It's not merely that, hey, we don't know what we're doing here and there isn't, it's a crapshoot for 99% of what we do offer you, or whatever, way we want to frame it. But rather, we figured out that we have to do better. And the way we can do better is by this joint enterprise in which we are continuously learning. And your data or your participation in this trial this time round may not help you, although it might, right? But it's going to help the next person, and you're going to get a better evidence base for your care based on what people did yesterday or tomorrow, so that in fact it's not as if it's all scary. It's rather we now have a pretty good plan for how to improve what is now an untenable situation. And I think if we I'm not a message person, so there are experts, I'm sure, at how to communicate better. than I've just phrased it. But I think that that's the general approach that we need to build. It's honest. It's what is really motivating both the policy interest and the ethics interest in going in this direction. And I think that is something people can get behind.
So I know we've got limited time. We've got about 8 people at least with questions. Let's go right to left and then back across.
First, thanks. That was really wonderful presentations. First, a quick comment. I was part of a group that published a systematic review meta-analysis in BMJ about 8 years ago, which looked at the health outcomes of patients who participate in trials, get drug X, and patients who, for whatever reason, didn't participate in the trial and also received drug X. And there's actually very large studies, and it does suggest that patients participating in trials are not being harmed by participation. There's limitations to the data, but in general, there's a very consistent signal, and there's extra things that happen that probably enhance health outcomes. So I think there is empiric data that does support the position you were saying earlier. The question I want to raise really relates to sort of collective right versus individual right. A number of studies that I've been involved with, cluster randomized control trials, or even individual-based trials where it's either patients having a cardiac arrest or acute trauma, where ethics agrees to let the randomization to the intervention happen. But then they want variable from center to center, but many will start to insist you must get consent to follow the patient for the outcomes. And I wonder at one level if it's an inconsistency between, or not an inconsistency, but a loss of practicality that if there was risk to the patient, it's happened. Ethics has accepted it. In other words, the interventions we've done have inherent risk. We've already given to the patient. I would claim that it's actually unethical not to follow the patient because whatever risk happened to the patient has happened. But it's a tragedy not to collect the data to then inform the next patients about what's going to happen. And I just wonder at one level if there's an issue between the individual versus the collective issues about getting data and going forward in individual rights versus collective rights.
I just want to thank you about your first and your second comment, and we're actively seeking, and I think I know the paper you're describing, but we're actively looking for evidence of exactly the sort that you just described. When you say ethics, presumably you mean an IRB allows, right? So a little bit careful there. I'm very sensitive on that point, right? So an ethics analysis and an IRB, should co-travel, but don't always. So that's just, a statement of fact. And in my life of chaired IRBs, I have tremendous regard for what IRB members, hard work they put into it. So I don't mean to slight IRBs. It's just that there isn't necessarily an isomorphic relationship between the best moral analysis of any particular case or issue and what an IRB rules. So there is a little bit of logic. I wanted to defend a little bit the experience that you've had with some IRBs who have said, all right, it's ethically justifiable to randomize in an emergency situation where it's impossible to get consent. Right? It's literally impossible, and the research is important enough, the question significant enough, and the risks to the patients acceptable enough, right? Not so high that we can't justify exposing people without their consent. Afterwards, right, the burden for failing to solicit people's consent is higher because now you can, right? Now, what you're raising is the question of, well, at what cost again, right? If people say no in sizable numbers, then in fact, your reasoning is exactly right. Then the risk to which they've been exposed, justified by the knowledge that would be gained, now has lost its rationale because now we can't gain the knowledge, right? We've lost the follow-up, or at least some of the data that are needed to get as much knowledge out of the trial as you could. So this goes back to the larger question we're all struggling with. If we were in a system in which patients understood and endorsed, right, the question that's being asked, or the kinds of questions that would be asked in this context, and felt comfortable, right, with the fair information practices being actually implemented, and felt confident that there would be transparency about the findings and a whole bunch of things that we could build in, we might be respecting patients in other ways, their rights and interests sufficiently such that you wouldn't need to get consent afterwards when they're available to you for the follow-up. But in the world we live in right now, we don't have that background apparatus. We don't have those practices and policies as a routine matter in place in healthcare institutions in terms of that kind of relationship with consumers and the public generally and the patients in the system more particularly. So what the IRB is proposing there is I think, I'd have to reflect more and know more about the particular study to be able to say, in this case, I think that was a right decision. But it certainly is a defensible position to take, because now you can't. And especially if it turns out, as is often the case, has been discussed earlier today, that the patients said, say yes. Did most of the patients say yes afterwards when you approach them for follow-up?
Most do, but some don't. The ones who don't
Or the ones that worry you?
have different outcomes.
Yeah, those are the ones that worry you. Right, so I'll stop.
Hi, Deborah Zarin from clinicaltrials.gov. I have, I guess, as a potential participant in a trial or a current patient, potential patient, I'd worry about a few things that you didn't mention. One is, I always think of the difference between research and clinical care as having to do with my relationship with the provider, whether their duty is to optimize my outcomes or whether their duty is to answer a research question. And similarly, the different or lack of financial and legal protections that would then come to me if I was in a trial versus clinical care. At least in this country at this time, sometimes those can be significant. And I think that, for example, the financial implications if I was harmed during clinical care versus harmed during a trial, there are certainly situations in this country still where you have no insurance coverage to cover your medical problems emanating from a clinical trial sometimes versus from clinical care. But mostly my concern is that I sit at clinicaltrials.gov, and we're now getting about 380 plus trials registered per week. The trial, it's very easy being in this room to think, oh yes, clinical trials are great. You're all planning great clinical trials. Of course we should try to be in them. But Rob knows as well as anyone else in this room that of the 380 trials that are registered each week, my guess is that if any of you guys read the protocols, you would maybe be willing to refer you or a loved one or anyone you knew to 10, maybe 20 of them. I mean, think about how many trials you read each week in a journal that you've heard of. Maybe 20, maybe 30, so out of 380. So most trials are actually of terrible quality. They either aren't asking a question that anyone who you could imagine would care about, or they don't have the internal validity to answer it in a reasonable manner. And we know only about 2/3 of trials of whatever quality ever get published. So I think it's very hard to have this conversation about lowering the barriers to participation or changing the barriers to participation in clinical trials without coming up with some way of figuring out which trials are good enough to do that. And so I'll give a challenge to everyone in this room. Take a week. You can easily search on clinicaltrials.gov, trials registered in the last week, and come up with any criterion you want. Funded by your company, funded by NIH, funded, whatever, at an institution that you love, at Johns Hopkins, and we will see if those trials, pass any, laugh test. But my guess is they won't. There are just a lot of terrible trials, and so I'm very worried about changing policies, in any way.
I know why you and I are friends, because we both have a tendency to hyperbole.
I'm just saying, well, hey,
And so
that's totally true.
yeah, I would think more than 10 out of 380 would be okay. But let me give a quick response, and then I'm interested in what the two of you would say quickly. There is no question. I'm completely sold, as you know, on the concept that we do way too many human experiments that are a complete waste of time when viewed objectively. Often in the guise that we have trainees that need to learn how to do things, and so it's okay to do a little study, but all the little studies added up across the whole enterprise, you're now able to see, and it's not a pretty picture. And I know that Mike has taken this seriously at NHLBI. He has a paper which is submitted that I think gives a lot of insight into these same issues. I would just so I'd say two things. Number one, we got a lot of things we got to fix at the same time to make this work, but it doesn't, to me, change the importance of the goal. But number two, I can't resist saying, you think you got problems with clinical trials, you should be at a major academic medical center watching what happens in clinical practice. You should feel the phone calls I get about people having major procedures without ever being told about the uncertainty, often with a clear financial interest of the health system. Even in our biggest academic centers, people are paid by the RVU now. And if you don't think there's an incentive there to do things that are unnecessary, even at our best academic centers, you should go look at it. So to me, it argues even more strongly. The ethics on both sides, I think, are very similar and increasingly similar as we move to the learning health system. So I'll give you 10 seconds each.
Yeah, no way could I endorse sort of saying that this solution where we would sort of place a different regulatory regime in place would just apply to any clinical trial. Anyone you want to do. I think if I didn't emphasize this enough in my talk, I'll do it now, that we need to do some serious thinking about if we're going to apply a different set of easier rules. Easier, but also still protective rules, different rules. We have to think through the criteria under which what would be eligible for that kind of treatment very seriously, but both from a clinical as well as from an ethical standpoint. And involving more patient groups in those conversations would be helpful too.
I would echo that. Look, it's an absolute rock bottom necessary condition of something like the transition we're all talking about here, that there be very, very careful scrutiny of any learning activity. I want to use some general term now so as to broaden the basis to include quality improvement through to your classic randomized clinical trial of any learning activity before it goes forward. That it's a value, right? That it can be ethically justified, which in this case means it can be justified in terms of its public health value or its scientific value or so on. On the conflict issue, this is, I think, one of the central concerns that people have, that somehow if it's an old and important issue in research ethics, the tension between the physician scientist and the physician friend, if you like, which Otto Guttentag introduced in the 1950s, I think. It's one of my favorite phrases at UCSF when they first started debating clinical research. And he said, oh no, physicians have to be either a physician scientist or a physician friend. They can't be both, right? And there's a lot of intuitive appeal to this notion that you can't conflict. If you put people in that position, what are they going to choose when there's a tension moment of science or their patient's interest? As a pragmatic matter, right, I'm not sure, and in fact, I'm fairly confident, again, this is sort of an assumption where evidence begs evidence, that to go to Rob's point, that conflict, right, poses far fewer threats to the well-being and rights and interests of patients than many other conflicts in clinical practice of the sort, for example, that the IOM's report on conflict of interest sort of pretty graphically highlighted. So while I'm not saying that's not a worry that has to be thought through here, I think it's a worry that's probably not nearly as much of a concern as other ways in which the interests of patients are not being well served because of conflicts that are more compelling, more thoroughgoing, and more pernicious.
To our two chairs, we're at our time, but we have people at the mics. What would you like us to do? I could go on all afternoon, of course, but one more question. Let's, Mike, why don't you tell us how aren't you head of the Learning Health System groups?
The people in this room are the head of the Learning Health System, and that's been very clear from the discussion over the past day or so. And in fact, I'll be very brief, two quick brief comments and two brief questions. And the first comment is reflective of what I just said, and that is, it's really an unusual privilege to be at a session in which each of the presentations strikes so directly to the heart of the matter and gives us a sense that we are at a tipping point. And it's a real credit to each of the panelists and to the planning committee for putting together a really extraordinary session. The second comment picks up on in a bit on what Deborah was referring to, and a theme that's been mentioned throughout the course of the meeting, and that is that words matter. And in many ways, words that, to draw on Ruth's theme, that were designed 40 years ago, are driving policy, they're driving program, they're driving priorities, and possibly in a distorted fashion. For example, wouldn't it be nice if rather than talking about quality versus research, we could be talking about the umbrella term care improvement and work around that as our decision analytic node. The questions I have are for whomever you want to triage them to, Rob. The first one refers back to the last point on your last slide. That is the multiple agencies involved: NIH, FDA, CDC, PCORI, and so forth, as potentially grouping together to develop and foster a more rational discussion about the rules that currently govern the use of clinical data and the research enterprise. Obviously, these are issues that are very much in the air, but it would be interesting to hear if there's a mechanism involved or an actual collaborative vehicle that's underway to effect that kind of consortium approach to the set of issues. Maybe that's a question for Mike or Joe or others in the room who represent the agencies involved. The last question picks up on the notion of Ruth's observation about the importance of respect as the principal decision criterion here. And that goes obviously to the heart of something that you were raising, Rob, earlier, and that is, where's the role of the clinician here? In order for that respect conversation to occur, in order to develop, whether it's a singular or an omnibus real form of consent, the clinician is going to have to be involved in some fashion. It would be interesting to hear how that strategy for getting them to be part of the overall buy-in to a continuous learning health system would proceed.
Well, I mean, in terms of sort of the agency collaboration, maybe you could look at the request for comment that OHRP put out that actually tries to align some of the policies more with HIPAA, and the HIPAA proposed rule that tried to accommodate the needs of researchers by asking for comment on whether general consent versus a more specific authorization ought to be sufficient for research. So it almost seems like there's some toes being dipped in the water, but it's a tough process to sort of get agencies that have their own priorities and needs to sort of come together on an issue of national priority. But I do think we're reaching more of a point where the timing for that is pretty optimal. And certainly if you were going to pursue something like a pilot, you would obviously want to get I think, multiple agencies involved in trying to script how that would go, ideally. I'll let somebody else speak to the physician involvement. I mean, generally, if you're using, if you use an approach to data where the physician is on the front lines of actually doing the research and additionally providing the clinical care, then you've got a model where the physician is intricately involved. I mean, certainly in terms of sort of who patients trust with their data, like survey after survey after survey shows that patients trust their doctors to make the right decisions for them, including decisions with respect to data sharing.
So on the point of the pivotal role of clinicians, and by the way, I love the people who are in the audience from the agencies to respond to the first point. That would be great. That would be very helpful. On the point of clinicians, I agree that clinicians are central. I want to return to that in my other 10 seconds or something. But I think also we should not forget the role of people who run healthcare institutions and systems, the payers as well, and the regulators. I don't think we can put this all on the back of clinicians. That said, I was very taken when Rob showed the Zerhouni-gram, and in the by 2012, in one of the boxes, one of the statements was participation in research should be a professional standard. Should be the professional standard. One of the elements in the framework that we put forward is something very similar to that. I think if it becomes normative that clinicians participate in research or see their role in the learning healthcare system as essential, not something not something they can choose not to do, but something they ought to do. It's a moral responsibility. Then part of that moral responsibility to participate as a professional, and I would include a broad spectrum of health professionals here, in the activity of generating new knowledge to improve the quality of healthcare and to make it a higher value system. Part of that obligation is working with the patients you take care of to develop that shared understanding about why it's important. So I do think there's a broader role, not just consent for this use at this time, but generally, as Devin was saying, since we do trust our clinicians to have our interests at heart, if our clinicians are backing this understanding of a learning health system, patients, I think, will find that part of why they should seriously consider backing it as well.
So I'll give a quick response. It would only be fitting that Nancy gets a question or comment if you have one, since we're honoring the role of patients in many ways here today. But what I would say is I think the two are actually linked, your 2 points. I think, one thing I've learned in 25 years of trying to deal with it is that there's a misperception in much of the public that the federal government is one entity and everybody gets along, and there's no rivalry and no hiding of information and knowledge among federal agencies. But I've learned there are even lawyers for each of the agencies that will threaten each other about how things are done. But I think this is an amazing opportunity where because of the other elements of the healthcare enterprise, for the electorate just voted, things are going to be a little more centralized, and anything that I would argue that the FDA, the NIH, CMS, now PCORI, AHRQ, DOD, and VA agreed on would happen. And the clearest statement that could be made by the federal government is that research is a professional responsibility, and put some muscle behind it by putting a little bit of the reimbursement system in play. And I think the providers would love it. My experience remains, even in the U.S., almost 100% of docs, if you give them a chance to answer a research question and it doesn't cause them to lose money or become terribly inefficient, they love to do it. And when you go to meetings with them about the results, it's like a love fest of, gee, we answered this question, isn't this amazing? It's like, being young again. So I think the two are related, and they would love it. If what we say is, it's not really your responsibility, but here's this protocol, go do it, and good luck. It's not going to happen. But I think there's a chance for it to really happen now. Nancy, comment?
Yeah, and when I say I'm going to be brief, I actually am brief, so this won't take long. First of all, great presentation. I took tons of notes. Second, there are places where advocates are involved in the research system now. Most of them are token efforts, and the advocate voice is marginalized. We're also not, y'all went to school. My mother-in-law got sick. That's why I'm here. I didn't go to school for what I do. So it needs to be thought through how to engage people. The second thing is that there are times when I look at our research and medical system and I feel like I've turned over a rock and it's really ugly down there, right? If y'all don't know the advocacy world or the patient group world or the consumer group world, if you turn over that rock, it can be as ugly as what you all live in, because it's all the same. So don't just say, oh, we're going to involve an advocacy group and it will be fine. Because there are crazy people out there, seriously, like with all of what we do. And so you need to do things like invite more people like me to meet. I don't want to go to more meetings, but there are people like me and groups that do what I do so that you can get to know people and start those interactions. Okay.
So very quickly, we'll continue with our presentation from Dr. Staub, but let's take about 3 or 4 minutes to go back and get our box lunches. Come back in relatively soon, and we're a little bit behind, but we'll start the lecture in about 5 minutes.